Okay, everyone, warm welcome to the World's Greenest Hospital Live. My name is Emma. I'm the Communication Officer at the Nordic Center for Sustainable Healthcare. And with me today, I have my colleague Rita.
Hi, everyone. I'm Rita. I'm the Project Officer here at the Nordic Center for Sustainable Healthcare.
Great. And before we jump into the live session, I just want to tell you a bit about the World's Greenest Hospital platform. So the World's Greenest Hospital is a digital platform where you can find sustainable solutions and products already implemented in hospitals today. And today we have around 28 solutions from both NCSH members and non-members, all united by one goal, which is to make the healthcare more sustainable. And Grønnköpingkið, as we call it, is like a one-stop shop where you can explore inspiring ideas or even discover specific products and technologies ready for your hospital. So this is how it looks like when you enter the platform. And as you can see, there are different categories. The categories are circular and waste solutions, energy solutions, interior solutions, medtech and ICT. We have sustainable hospital buildings, the green kidney clinic, and the international arena. And these categories contains the different solutions. So let's go to one of them. So we're in the category medtech and ICT. And here you can see that the supplier is Medclaire. It's one of our members. The solution, the impact, and where you can find the solution. Now, let's click on expand. Then we can see the contact information from Medclaire. And if you want to have a look, take a look around the World's Greenest Hospital platform. You can either visit it by going through our webpage, the Nordic Center for Sustainable Healthcare. You're going to find it in the upper left corner, or you can go directly to the World's Greenest Hospital. We will provide the links in the chat here in Teams. And if you have a product or a solution that you would like to showcase, you can also email us. And the email address is also provided in the chat here. Great. I would also like to tell you a bit about the upcoming events we have at the Nordic Center 2026. So the 29th of January, we have the Nordic Outlook. The 27th of February, we have the World's Greenest Hospital Live again. 27th of March, we have a crash course in sustainable healthcare. And the 29th of May, we have the World's Greenest Hospital Live once again before our summer holidays. And this will be updated again during springtime next year. So yes, that was all from me. Thank you so much. And I will give the mic to Rita.
Thank you so much, Emma. Yeah, so I think we're ready now to start with today's agenda. So I just wanted to present our speakers for today. So we're going to first hear from Silentia, from Jonas. He's a sustainability specialist, and he's going to talk about resource efficient privacy. Then at 2:20, we have Halton, and Jörgen is the sales manager. He's going to talk about Laminar airflow ceilings, sustainable choices and applications. At 2:35, we have Stryker and Nina talking about providing sustainability, the Neptune 3 life cycle assessment published in scientific reports, and she's an associate brand manager for Neptune. And at 2:50, we have Sahlgrenska University Hospital, Maria. She's the environmental strategist, and she's going to talk about the journey towards a sustainable hospital. After this, we're going to have an open discussion. But of course, if we have time between the presentations, you are also free as people that are here listening to this World's Greenest Hospital Live. They are free to ask questions. I'll be moderating the session today. But in the end, we'll also have an open discussion in order to have some more answers and some more questions, and to hear our speakers a bit more. And at 2:30, we're going to end today's World's Greenest Hospital?
Today, I will be talking to you about patient privacy solutions, something quite niche, but with a potential big impact on environmental performance, financial performance, or an infection control within hospital wards. But before I get into the specifics of our solution and what happens in terms of the environment, I will just take you back to the beginning and the problem. And if you can click to the next slide, then we will start back in the 1980s, because back in 1989, Dag and Jörgen were approached by a family member working in a hospital, and she had noticed a problem, and she almost had could almost call it a request, but she wanted them to look into hospital privacy curtains, because she thought there was a few problems with them. Not only was there a lack of privacy, there was also something with design, but most importantly, there was a big hygiene problem. And that actually led to Dag and Jörgen, the two founders, inventing the first healthcare-specific folding screen to combat the hygiene-related problems. So fast forward to today, and you can click yes, thank you. And here's some archive pictures from back in the 90s with the first models. But a lot has happened since then, and today we at Silentia have what we call a modular screen system, with anything from folding screens like the models you saw before on the archive pictures, but also shower screens and even pop-up hospitals for emergency situations. And if you click once more, you should be able, yeah, there you go. Not the highest quality picture, but an overview of the full system with a lot of options. And if you click once more, there's a picture from a recent installation in Norway that I thought was quite a nice room with a wooden floor. We don't see that often in hospitals. But this slide that you see here is I would say an oversimplification, but a really nice illustration of what really happens when you move from a textile-based patient privacy solution to a hard surface base like the Silentia screen. I'll just start at the top. So with the Silentia screen, post-installation, what happens is you have a very resource-efficient way of cleaning, because the hard surface fits with the normal routines that a cleaning department or an EVS department already has, because you clean the screen like you would clean a tabletop. So what normally happens is we see that the cleaning department does maybe a daily walkthrough and they clean the screen. So you have daily cleaning of the screen. But looking at curtains, it's a totally different scenario, because it requires dedicated labor. And what I mean by dedicated labor is you need to have someone who can only carry out that task of cleaning the curtain. The specifics are, I guess there's two different types of curtains that we see here on the illustration. And that's also what we typically see in the hospitals. You have disposable curtains, and it's kind of in the name, you dispose of them when you want to clean them. You don't really reuse them. Then there's the textile curtains. Those are the classic ones that you have to transport to an industrial laundering plant. So what happens with the disposable curtains is you need some sort of storage, you need to transport the curtain, and you need a lot of logistics, because you have someone in the hospital ward or department that has to coordinate with whoever is switching out the curtain. They have to come in, take the curtain down, put up a new one, and that repeats itself whenever you need to clean it. Also, in most hospitals, when you take the curtain down and put up a new one, there's downtime in the room. You can't have patients in the room when you're doing that. The textile curtains, it's very much the same, but you transport the curtain to a laundering plant, and there you're using electricity, generating wastewater, and probably also using chemicals of some sort. And because it requires so many logistics to clean the curtains, what usually happens is you don't really clean them because it requires too much logistics, it's too expensive. So what I usually say is there's no synergy between the environmental aspect and the infection control aspect. Because if you want to have a high level of hygiene with curtains, you have to compromise greatly with environmental performance, because you have to switch them out and you to dispose of curtains or clean them all the time. On the other hand, if you want to prioritize environmental aspects, you have to stop cleaning your curtains, which isn't really a great solution. And it's not a great solution because if we click once more, there is a trickle-down effect of not cleaning your curtains, and that is hospital-associated infections. If you stop cleaning your curtains, you have a high-touch surface that isn't being cleaned, and that is risking hospital-associated infection. And with those comes potential extra bed days, more medicine, more labor, and so on. Not very good for the environment either. So in essence, you need a solution that could be cleaned very resource efficiently. Moving on. So now I'll just talk a little bit about our organization and how we approach design and sustainability. We produce our screens in Falkenberg, Sweden. We have an ISO certified factory, and we get 100% renewable energy from Falkenberg Energy. Yeah. We have 5 eco-design principles, and you can look at them in 2 ways, or we look at them in 2 ways. It's both guiding principles in the way we design our products and design new products. We have to make sure that they live up to each principle, but it's also a set of values that we hope to offer to the customer. So they should also be able to check each thing and say, we actually got this out of purchasing Silentia screens. Moving on, I will just take some of the design principles and highlight them with cases and initiatives that we do within these eco-design principles. So taking repairability, we have a few initiatives that we try to focus on to increase the chance of repairability out in the hospital. We have EasyLog. It's basically a product passport where we can store information about what type of screen it is, who's the customer, which room is it installed in, and if we carry out repairs during its lifetime, or if we need to move it, we can also store that information on there. It's a little code that's printed on every screen. We designed them in a modular way. Oh, if we go back just a little bit, we designed them in a modular way so you can repair parts of the screen and not replace the full screen. We also have repair guides that we can send to technical departments in hope of them carrying out the repairs locally and efficiently. And we have spare parts, of course, to make that happen. And now we can move on. So just a quick case story from Denmark and a new hospital that was being built called Gødstrup. Gødstrup was replacing 2 older hospitals, and in those hospitals we had delivered a lot of screens. So we said, why not use the product passport to recycle and refurbish most of those screens, and it ended up being more than 100 old screens, making it to the new hospital and mixing them with newly purchased screens. The project department was super happy because it helped them live up to recycling quota, but it also had quite a financial benefit. And if we move on, that would only be possible with a long lifetime or great durability. So we have a technical lifetime of 10 years, but we know that the screens can last for up to 30 years. And if we move on, I'll show you why we know they can last so long. Because we have a case story in Sweden from Växjö. And Växjö was actually one of the first customers at Silentia. So all the way back in 1994, back when I was born, actually, they started purchasing screens. So they were one of the early adopters. And last year we were able to do a walkthrough. And there we found 273 screens with an average lifetime of 9.8 years. But the oldest ones, the ones that they started purchasing 30 years ago, were still in operation, still doing fine. Quite a testament to the quality of the screens. And it also was a chance for us to say, okay, that's pretty interesting. What if Silentia had never existed? What if they had purchased curtains at the same time that they purchased the screens, or instead of purchasing the screens? And if we assume quarterly laundering, so quite a drastic hygiene downgrade, a life cycle analysis tells us that they would have used 334,000 kilowatt hour, and they would have generated 1.2 million liters of wastewater in cleaning curtains. Or if they had disposable curtains, they would have generated around 22.3 tons of plastic waste. And that's assuming quarterly laundering. So you can only imagine if they had say monthly laundering or something like that. Instead, what they actually have in real life is they have about 4.4 tons worth of screens still in operation, so not considered waste. All right, moving on. We produce annual sustainability reports with Klapir, an Icelandic company producing sustainability reports. We do full scope 1, 2, and 3 ESG statements. We do data trends analysis and describe new initiatives and also case stories that have some sort of relation to sustainability. And I'm happy to send over the reports if anyone is interested. Just reach out to me. Yeah. And then one last slide. That's me, and feel free to reach out. I hope I held under 10 minutes. Thank you guys for listening in.
Jonas, thank you so much. That was perfect. You were right in the 10 minutes, I think, but we still have time for just one question. So if someone wants to ask a question to Jonas now, please feel free. You can just, yeah, perfect. Sarah, yes, of course.
Sorry, I didn't have a question.
Oh, that's okay. Does anyone have a question? Okay, if not, I actually do have a question, so I think we can take this 2 minutes for that question. So Jonas, you were talking about just now about the curtains and the LCA that you did to understand if they were using curtains instead, what would be the results. Is there an LCA for the screens?
Well, yes, there's a little bit of a, I was a little sad that today was the date of this presentation, because tomorrow I am going to the Danish Technical University to have a presentation, or to see a presentation of an LCA done to benchmark our screens towards disposable curtains. So the question is, right now, no, but tomorrow, yes.
Perfect.
Yeah.
Okay, but that sounds super good.
Coming
So
soon.
maybe exactly. So maybe next time in a couple, I don't know, we do this World Greenest Hospital every once in a while, as you saw. So maybe next time, if you come and present, you'll have new results to present as well and new information, which is super interesting. That is great to hear. Thank you so much, Jonas, for the presentation. We're gonna now jump to Jörgen. So,
Yes.
Jörgen, you probably cannot share your screen as well. We did realize that there's some type of issue with that. So I'm going to share the screen as well for you. And you can just do exactly as Jonas and just let me know when you want me to skip, okay?
But you can't see my screen? It seems
Oh,
like I'm
actually we
sharing.
do. Yeah. Oh, perfect.
Yeah,
Okay,
yeah.
sorry. Amazing. Perfect. So please, the floor is yours.
Yeah, okay. Thanks. Yeah, thank you for giving me the chance to have the presentation today during the webinar. My name is Jörgen Stenqvist, based in Stockholm, Sweden, and representing Halton Health and Clean Room. So, and the presentation or today's webinar from my side will contain information about laminar airflow ceilings. But first, really short, Halton Group. We are a Finnish family company with nearly 2,000 employees. And we are market leaders in ventilation for highly specified environments, meaning, for example, clean rooms, laboratories, but also ORs, operating rooms, and so on. And Halton Health and Clean Room is a business segment within Halton, and we focus on, you could say, buildings and environments that is a little bit higher requirements in, such as HEPA filtered, where HEPA filtered air is required. And we provide both turnkey solutions where we take on the whole, building of the whole room or the operating room, for example, but also products and services. So In terms of services, it's about validation measurements or measuring filters and so on. But also we could help out with the CFD simulations in really early stages before the actual design work has started, more or less. So that's a little bit about us. And when we normally talk about our products, or when we go into discussions with customers and clients, we always try to focus on risks, because working in operating rooms, for example, which I will focus on today, it's all about mitigating risks. And the situation we're facing in the future, and this is not far from now, is antibiotic resistance. And the case is, unfortunately, that in many countries, the problem is already there. We have the luxury in the Nordics, and especially in Sweden, that this is, we still can treat a lot of patients with antibiotic. But looking at 2050, this will antibiotic resistance will stand for more deaths than cancer. So therefore, this is something that is really, really important for us all. And if we go into infections related to surgical treatments or surgical site infections, so that we call them. These kind of infections, well, they result in not just extra cost, additional costs, but also a lot of suffering for the patients. We also know that if you get an infection, you go back and forth to the hospital several times just to get the proper treatment and to recover. In the worst cases, yeah, then you need to maybe amputate, or worst case, it could lead to death. So if we look about sustainability, this is actually a sustainability factor for the society to focus on, well, mitigating risk for getting infections in hospitals and in operating rooms. Long time ago, not that long as, well, after I was born, but in beginning of the 80s, 83, there was a report delivered by Lidwell, where it's about correlation between surgical site infections and colony-forming units. So colony-forming units, you could say it's bacteria that could travel in the room, and bacteria cannot take themselves from A to B without something to grab onto, and that something is actually particles. Particles, it could be released also from humans, of course, and bacteria also contains a lot of bacteria, but it also can come from the surrounding areas. So looking at the classification, and when we measure particles, we are actually, if we look at infection-prone surgery for hips and knees, for example, we equal ISO class 5, which is really, really tough. And if we are there or below, then we could minimize the risks for bacteria, for sure, to infect the patients. As we see it, there is a critical place in the room, and that's the most critical part of the room, and where the risks should be mitigated at first hand, is where you have the instrument tables, where the staff are and where the patient is. So maybe in some of the ORs, if you have been there, you can see a circle in the floor, or maybe a square or something, and that is actually an area showing this clean zone or sterile zone or whatever they call it. Now getting a little bit more into ventilation and our products. There are two ways of adding air, or there are two airflow principles. One is turbulent airflow, where you mix the particles, or you kind of, the pollution in the air is mixed. So if you add a lot of air, clean air, HEPA filtered air, then the spread out, you reduce the concentration of pollution in the air. That's one way of doing it. The risk in that kind of situation is it's more sensitive to door openings. It's more sensitive what is happening in the surrounding of the room. I mean, in the periphery. So if someone is not dressed properly or does something that could wipe up some dust or something, you will see it quite soon in the center of the room at the patient if you place a particle counter there. The other way of doing it is to create a unidirectional flow. It's kind of you kind of displace, you try to keep out the pollution from the area, the critical area, and you do that by adding air that goes from the ceiling and downwards. So if you handle that correctly, you can measure that you have a proper laminar airflow if you actually try to force particles into that area and have a measurement inside it. If you try a particle counter inside it, you could see if it works or not. So laminar airflow ceilings, obviously, they work with the as a unidirectional airflow solution, and that is and the aim of this is, or what we know is that when we measure it, we have an average of between 0 and 2 CFUs in that clean zone for a unidirectional flow ceiling, also called laminar airflow ceiling. So as we see it, since every CFU is a risk, why should we not aim for 0? Coming back to the risk for infection and the antibiotic resistance, this is the way we see it. Looking at some of the regulations, yes, it's allowed to be below 10. But as we see it in the future, we should focus on heading towards 0. What is important then? Yeah, then to create this laminar airflow, you need to, and a good environment in the room, you must you should supply the air in a correct manner, and you create this laminar airflow with these loft ceilings. They can be of different shape, you could adapt them to the different problems or challenges you have in the room, such as vent ducts coming in from certain directions, or maybe if you need a larger area because you're in a hybrid room or something, then you could make them oval or square or wherever. But these laminar ceilings are more or less always tailor-made, just because it's a matter of reducing costs and risks in the long term. So it might be that in some cases the ceiling itself, the product, costs more, but reducing the cost, it will reduce the cost in the project or for the society in the end. Yeah. Also important that we take out the air properly. And this is just to avoid unnecessary turbulence in the room or stagnation zones. So you focus when you design your ventilation system, you should focus on supply, but also exhaust units. So this in combination, and this is also something we know from thousands of measurements, is critical. Therefore, we also know that even though we are quite close to 0 CFUs in average in the center of the room, with a proper exhaust system, you could also be very low in the periphery of the room. So in average, we are between 5 and 10 CFUs outside the clean zone. Yeah, a few pictures just so you understand what we're talking about when you go into an OR. This is a good example of a circular laminar ceiling. It's actually a photo from Sundsvall in Sweden, northern Sweden. And this is another example of an oval loft ceiling. I've done like this also. I added some general facts for you to look at and to consider if you have time afterwards. I will leave it with the presentation, but I will not go through it now since the time is limited. But you can read it yourself if you like. And you find us here under Sustainable Hospital Buildings. If you go down the list there, you will find us in the bottom. And I've also added a few references, if you like, to the right. Yep. Thanks.
Perfect. Thank you so much, Jörgen. That was great to hear. So I don't think we have a lot of time for questions right now, but we will definitely have some time in the end. So if anyone has any question it would like to ask to Jörgen about the product, just wait a few more minutes, and in the end we will have some open discussion, and we'll be happy. He will be happy to answer the questions, I'm sure. And I see that Nina is already sharing the screen. Perfect, Nina. So the floor is yours.
Thank you. Hi, everyone. So indeed, I'm Nina. Thanks for joining today's session. I'm very excited to walk you through what Neptune actually is, also why it exists and how it can support staff safety, but also workflow efficiency, and obviously for today's session, more specifically regarding sustainability in hospitals. In case something is not clear, just drop a question in the chat box. We will have time to discuss the questions afterwards. So before actually we dive into Neptune itself, I'd like to start with why we do what we do. Obviously, Stryker is a big medtech company, and actually our mission is pretty simple. We want to make healthcare better, but a very important piece, and that is that we want to do this together with our customers. And actually, Neptune is a great example of that mission in action, because Neptune wasn't created in isolation. It was really co-designed with nurses and surgical teams, built around the challenges they actually are facing on a daily basis when dealing with surgical fluid waste. The goal of that development of Neptune was actually pretty clear. They really wanted to improve safety in the operating room, make workflows more efficient, and also reduce that environmental burden of traditional waste handling methods. The principle actually of Neptune is pretty simple. So it is a mobile closed system designed to collect, to also transport, and also dispose the surgical fluids. It has actually a 24-liter capacity, allowing the teams to manage even high procedures without interruption. And because the unit is mobile, staff can move the fluids without actually the need of lifting the weights. After the case, the fluids are automatically emptied and the device is cleaned at a docking station. And also, finally, Neptune also integrates smoke evacuation, giving actually the teams one system that manage both fluid waste management while protecting against surgical smoke at the same time. If you take a closer look at how Neptune is actually used in practice, it has three key components. So you've got Neptune 3 rover, but also the manifold and a docking station. So the manifolds are only disposable and an essential part of the fully closed system. So before each procedure, the manifold is inserted in the Neptune 3 rover, creating also that protected, sealed pathway for all surgical fluids. And then on the right, you can see the docking station. This is where the rover is then connected after the surgery. And the docking station automatically empties and cleans the rover inside. So that means staff don't need to lift, open, manually handle any fluids. So what you can see here, it's the system stays closed, actually from the start until the end, basically. So to help you understand what Neptune actually changes, let's first explain shortly how surgical fluid waste is handled today. So when we talk about surgical fluid waste, we simply mean all the fluid that is removed from the patient during a procedure. So blood, irrigation fluids, rinsing solutions, and so on. An easy example is an arthroscopy procedure, where surgeons continuously flush a joint of a patient with fluids to get a better view on the anatomy. All of that fluid needs to be suctioned out and collected safely throughout the procedure. And to give you a perspective, for one procedure that can go up until 10 liters for one procedure. So today, this is typically done with multiple plastic canisters connected to wall suction. So staff have to replace these canisters as they fill, carry them out of the OR, and manually dispose the liquids afterwards. So a lot of manual handling, a lot of plastic waste, and a lot of exposure risks during transport and so on. To understand the sustainability impact of these methods, it's important to first look at how surgical fluid waste is currently eliminated. So typically, the fluids are collected in the canisters, and then after which they are collected in separate plastic bags, which are then sealed in containers, carried out of the OR, transported to the hospital waste service provider, where they are actually all incinerated. So a process that obviously generates a significant CO2 emission and other pollutants. So to put the environmental impact into perspective, let's look at a few numbers. So today, healthcare sector is responsible for around 7% of a country's total CO2 footprint. For comparison, the aviation industry, which we often think and which is as a major polluter, accounts for 4.5%. But it just puts it into perspective on how big the impact of healthcare actually is. And then if we zoom on hospital waste, we see that 33% of all hospital waste comes from the operating room, which obviously makes sense. We see high sterility standards, a lot of packages and disposables. But what is actually striking is that 40% of that waste comes from suction canisters alone. So what becomes immediately clear here is that traditional canister systems are a major contributor to the environmental footprint of a hospital. They require a large amount of plastic, creating significant logistical waste. Ultimately, all of this material needs to be incinerated, which drives up that CO2 emission. But of course, as we know, every solution has an environmental footprint, including Neptune 3. So the real question we wanted to answer was, is Neptune genuinely more sustainable compared to canisters when you look at the full life cycle of both products? And that is exactly why we conducted the life cycle assessment to compare both systems fairly and to quantify the impact across their entire journey. So in 2023, we conducted this life cycle assessment. Actually, Stryker didn't conduct it, but Green Cycle, which is an independent sustainability research company. And to explain, maybe you know, but an LCA is a very comprehensive study that evaluates every stage of each product's life cycle, from manufacturing and transport to daily use and disposal. So for today, I won't take you through the entire technical details, but I will focus on the key results that truly matter for your hospital. And as you can see on this slide, we're very incredibly proud that this study now has been published in Scientific Reports, which is part of the Nature journal family. That gives obviously the findings of this study scientific credibility, but also reinforces the importance of really understanding the impact of waste management, not just from safety or efficiency perspective, but also from an environmental one. So before we look at the results, it's important to understand what the life cycle assessment measured, just to make it visible. You see, the study took every step of both systems. So canisters, they took the materials, transportation, energy, everything. And they did the same for Neptune. So including the rover, the manifold, but also the docking, energy, and so on. So if we take a look at the results, Green Cycle compared both systems across a wide range of real-world scenarios and procedures. You can see on this graph procedures that generate 0.1 liter, so small fluid amounts, up until 24 liter. This makes the comparison relevant for almost every specialty, but also every hospital workflow, because not all procedures are generating a lot of fluids, obviously. And what becomes very clear right away is that you see Neptune's environmental impact stays very consistent regardless of the procedure size. In every scenario, Neptune shows a lower CO2 footprint compared to canisters. For canisters, the environmental impact, like you can see on this graph, increases sharply once procedures generate more than 5 liters, simply because more plastic canisters, more containers, more production, more transport, and more incineration. And then the results regarding fossil resources, we see a very similar pattern. Neptune stays stable and low across all procedure volumes because it relies on less disposables compared to canisters. And canisters, on the other hand, you can see again, same pattern from 5 liters onwards, the gap becomes very, very large. Before I wrap up, there is one more important point I want to highlight. While obviously this LCA focused mainly on the environmental impact, the scientific report's publication also reinforced the other benefits that Neptune was designed for. So they confirm it shows a clear improvement in terms of staff efficiency, but also a reduction in materials, ergonomics, and safety, while also providing clarity on and reassurance around the safe drainage practices. I think it seems obvious, like in terms of efficiency, reduction of materials, and safety, that Neptune is an improvement compared to canisters. But what might need a little bit more context is the fact that the publication also confirms that the drainage is considered as safe. This LCA was actually done in the Netherlands, a country where Neptune was initially not allowed because surgical fluids couldn't legally be discharged into the drain. And that was obviously very frustrating because a lot of hospitals wanted to work with Neptune, but they were kind of blocked. So when Stryker engaged with the government of the Netherlands, they were open to reconsider this if we could demonstrate that Neptune was more sustainable, a more safe solution compared to canisters. And as you saw today in the presentation, this seemed to be the case. And the government also updated the legislation thanks to that. And this is also reflected in the publication, who also highlights that Neptune is already widely used internationally and aligns with the existing hospital practices. So, and obviously, again, as we are very proud, I wanted to dedicate a specific slide showing the publication. You can see a QR code, so if you want, you can freely access the study. I will also drop a link of the study in the chat later on. So in case there are, I don't know how we are in terms of timing, Emma, yeah.
You still have 3 minutes. So if anyone has any questions, please feel free to ask to Nina. This is a very quiet group that we have here. Okay, I guess there's no questions. Well, at least for now. But I do have one. So maybe since we do have time, how scalable is Neptune for hospitals that are now starting their journey to become a bit more green?
Yeah, that's a good question. So obviously we've got several ways of installing Neptune in a hospital. We've got also different kind of solutions which need to be aligned with customers in terms of financial models, in terms of service packages and so on. And that is actually also an important piece of the local sales reps is to really sit down with the customer, like what is the need of your hospital and how can we help to meet those needs together. And that is obviously very independent, but we've got multiple solutions to scale that solution depending on the hospital's possibilities, basically.
Okay, perfect. So it's very adaptable as well to the needs of every hospital, which is super
Absolutely.
important, of course. Okay, that sounds really great. So thank you so much, Nina. We can now move to Maria. Maria, are you there? Perfect. Great. And we see your screen. So the floor is yours. Thank you so much for joining us today as well.
Okay, go back. Sorry. Yeah, hello. I'm Maria. I work as an environmental strategist at the Sahlgrenska University Hospital in Gothenburg. And I will try to talk to you about how we work with sustainability at the hospital. But first, I want to just present our hospital. I don't know how many of you know about Sahlgrenska. We are about 17,000 employees. We have 1,100 beds for patients, and we take about 390 patients per year. We are a big organization. And we are mainly 3 big hospital sites. It's the Östra sjukhuset with Drottning Silvias barnsjukhus. And we have Sahlgrenska and Mölndal. And we also have forensic psychiatry at Rågården, and at Högsbo Hospital we have more of rehabilitation. So, and we also have receptions in the town, smaller places, and we run the laboratories in the region, all the region laboratories. And we also have the ambulance and hospital care at home. That's the Sahlgrenska. And we are a part of the region of Västra Götaland. And we have this, in the region, we have this sustainability policy, the vision, the good life for our planet and for every human being. And to achieve this vision, we must work together for sustainable development, both for now and for future generations. And we are one of the Sweden's largest employees, and Sahlgrenska University Hospital is the biggest administration within the region. And the region has these goals, these sustainability goals that we follow. We take them and we see how can we work with them and then set our environmental goals. So these 7 goals we work with now, and they are connected to the sustainability goals within the Agenda 2030. We have it's 4 goals to ecological sustainability and 3 goals that we work with social sustainability. And at Sahlgrenska, we work with we have this sustainability is embedded in every decision, and we have this sustainability education for all employees. That this is a mandatory education that the region has. They have done it, so we need to do it. And this year we have been ISO 14001 certified. We have been working with this system for many years, but now we are certified as well. And we also work with health promotion, because the patients that come to us, if they come with a heart attack, and then we don't want to see them again, so we do health promotion for them so they don't come back. It's the exercise, alcohol habits, eating habits, and tobacco habits. That's something we screen with the patients. And a way of working with sustainability is choosing wisely. And this is a way that many of our clinics are working with, and do have in mind when it comes to which examinations and treatments our patients should undergo. It's evidence-based clinical choices. More is not always better, and high-value healthcare can be low-carbon healthcare. So we know that about 10%, I think it is, examinations and tests are unnecessary for our patients. So we need to see what do they really need to do, and some examinations can do more harm than do good. And now I want to present some examples of how we work, what we do here in Sahlgrenska, more specific. One is we are working on reduce the unnecessary use of plastic gloves. As you see, we use a little bit more than 25 million examination gloves per year. And to take this issue, we know that people use gloves more than they need to. And we have produced an information film within, and the one who make it is our environmental department, and we have this hygiene department that see that care hygiene. I don't really know what to say in English, but and doctors and nurses took this film, and we did it together. And it's only about film about only use gloves when it's necessary. And when it's necessary is when it's there is risk of getting bodily fluids on your hands. And gloves also provide a false sense of security in clean work. And a clean sanitized hand reduces the risk of hand spread infection. And we have a goal, an environmental goal at Sahlgrenska for this year and a couple of years back. But this year we need to reduce the use by 20% compared to 2020. In 2020, we used about 30 million gloves that year, but that's pandemic year, so we can go lower. And when I looked at the numbers just this week, we will reach this goal. So I hope it hasn't been any big infection or something throughout the hospital this last month. But we will reach that goal, and we can maybe do better, even better next year. However, we have a challenge in that that the production of care changes. It increases and decreases, which affects how many gloves are used. And we are planning we need to review how many gloves are reasonable to use, and also link the number of care sessions. So we need to how much care we produce to how many gloves we use. And another challenge we have with the gloves is that more gloves fall out of the box and need to be discarded. And I have a co-worker one of our nurses in the thoracic clinic. He did a little bit of counting how 1 week this May on how many gloves that taking out 1 or 2 gloves that he needed to have, and how many fell out of the box. And due to that week, and he had counted that for over a year's time, we will lose about 88,000 gloves that needed to be discarded and didn't got used, because they go on the floor and then they get dirty, and then you need to throw that away. And he will work more with that next year as well. And that was like a little tiny bit, just one of our challenges. But we do also do bigger things that is good. And the Sustainability Award is a regional award. And the winners at this year one of the winners was the urology clinic at Sahlgrenska University Hospital. And the project introduced replacing cystoscopy with urine samples in following up after urinary bladder cancer. And a year ago, the urology clinic began using the new method as a part of a pilot project. And specifically, this means that cystoscopy, which is entering the bladder with a camera in the urethra, is replaced with a urine sample for patients who have been treated for bladder cancer. And if the sample shows normal values, the patient does not need to undergo cystoscopy. And for the quarter of patients who have a positive urine sample, cystoscopy is still required. And before this method, the patients did all the follow-ups with the cystoscopy every 3 months. But now they only need to do it once a year, or if they have a positive on the urine sample. And this saves money for doctors and nurses. The patients doesn't need to have a camera up their urethra, and it improves patients' health. And another thing that we are proud of is this advanced pediatric healthcare at home. And the doctors at the Children's Hospital, they see what patients can be treated at home. And then the nurses go home to the patients and give them antibiotics or vaccines. They take the vital, like blood pressure and height and weight and all those things. And the patients doesn't need to go to the hospital to do that. And with this, we see that the nurses need to travel, but then they travel with a car that's environmentally friendly, that we don't can, if the patients are coming to the hospital, they all drive their own car, and we don't know what kind of car they use. And they can plan the route, how to travel between patients in an effective way. Children and parents doesn't need to go to hospital and spend the whole day or so at the hospital. They can be home where they are safe in their environment where they feel safe. And they also can go to schools if they have a child that needs like antibiotics or something. They can go to school, the child go to the school nurse, and they meet these nurses there, and he or she can get the treatment and then go back to class and miss a whole day of school. So this is something I think is good for all three. We save money for the parents that doesn't need to be at home and go to the hospital with the children, and we save money and environment, and everything is good with this, I think. And that was what I had to say. Thank you for your time.
Thank you so much, Maria. Such a great presentation. And it's just in time. So we're starting the open discussion just now. And we already saw that you had some questions that you wrote in the chat. It's perfect. I saw that Nina answered to one of the questions. But maybe we can, Jörgen, if you want to ask your question directly to Maria, or maybe you prefer me to read it.
No, but I can do it.
Perfect.
Thanks,
Yes.
Maria, for a great presentation. A little bit related to what I presented. I was just curious about the Västra Götalandsregionen. Have you done any evaluation on surgical site infections and how they affect your sustainability targets? I think you pointed it out in the end here that unnecessary travels and so on also stresses that's also a way of stressing the environment, doing things twice, or maybe if you get an infection you have to go maybe 4 or 5 times back and forth, and all the workforce as well needed. So have you done any evaluation on that in your region?
Not that I know, actually, is the answer.
No, because it's a lot of discussions when we talk about green things. You always think about material and stuff like that, and you look at what you see, but you don't think about the system. And if we mistreat patients, then you stress the society system, and that causes much more trouble than maybe focusing on reducing, switching from one material to another. That was my thought behind the question.
I'm not sure if we have done any actual evaluation to see that. But it's an interesting question that we will take on, I think.
Tack.
Thank you so much to both of you. I also see here that Jari has a question again for Nina. I don't know if you prefer to have it answered. Nina, do you want to answer now?
Yeah, of course, indeed. And if I understood well, Jari, you mean systems that are still using canisters or other? Hi. Hello.
Yeah, exactly. And thanks for the LCA methodology. I'm curious about that, and I will have a second look on your study. Just thinking, because I read your study that actually the incineration of liquids and waste boxes the hotspot of the whole system. So I was thinking that if we use still containers and this kind of devices that discharges the liquids, so you don't have to incinerate the liquids and either the waste boxes. So also container systems have this kind of options. Have you thought about what kind of impacts that kind of system has compared to what you have studied? Just curious, because it's part of the container system as well. But you haven't studied that kind of system in your study. Just curious.
So this LCA is indeed focused on the use of canisters, which we actually see as in the main hospitals are still using this kind of solution. It does not involve other potential solutions that are on the market. So no, that is only canisters compared to Neptune. Yeah, indeed.
Okay, so maybe further studies are needed, to include this kind of solutions for the comparison.
Well, yeah, of course, we can only do a study from our device with indeed like what we currently see in practice as the main solution canisters. In
the Nordics, I see more and more this kind of solutions. But okay, thank you.
Yeah, okay.
Perfect. Thank you so much. Does anyone else has a question? You are welcome to write it in the chat if you do have a question. We can still use this minutes to, I do have some questions also. So maybe taking on what was just said to Nina, maybe Nina, I would also like to ask you how many hospitals currently use Neptune and what trend do you see in the adoption? I think you're muted, Nina.
Sorry.
Okay.
Currently, in Europe, we've got more than 4,000 rovers spread. So what we see is indeed that the demand is increasing because hospitals are really seeking for solutions that are indeed improving their CO2 input while also indeed protecting staff because we see a lot of burden on staff members currently. So anything that also can protect them in terms of ergonomics, exposure to liquids, while also having that protection of smoke is really something what we see as an important part of the acceleration. So it is indeed building momentum, absolutely, Great
to hear. And Jörgen, So when you were talking, I was just thinking, can the laminar airflow ceilings be fitted also in hybrid rooms in which you have the traditional operating room, but also with the integrated diagnostic imaging equipment? Is that possible?
Sorry, the phone was muted. Yes, it's possible. We have done it in several places. For example, in Maria's region. So it's just a matter of design, honestly. And depending if it's a floor standing or a ceiling mounted diagnostic unit, it will look different, but it's fully possible. You also see in many of these cases that you have a mixed airflow solutions as well in some cases. But I think that is mainly because there is maybe not knowledge about the alternatives.
Okay, thank you so much. So once again, if you have any other questions, please feel free to write them in the chat. I will take this last minutes just to ask one final question also to Maria. But then I guess most of our speakers are also happy to share the slides. So as it was mentioned, so if you are interested in getting the slides, you will also all of you receive an email, following up email from Emma with some more information about the World's Greenest Hospital and also some information about today's session, that it's also being recorded. So you will also be able to see it online later on and share it with colleagues or anyone else who find it could be interesting to see the discussion that we had today. And I just saw that Diego also shared the calendar of our events and our reports. So stay updated also on our news. So Maria, just to finish before we all disconnect for today, or maybe continue our work, I wanted to ask you, how do you work to incorporate the 3 dimensions that you also mentioned into all the decisions?
Well, a couple of years ago, one of my previous colleagues, they took this sustainability filter. It's not that advanced. It's just when you think about, if we're going to do this, how would that affect the environment? How will that affect the social, and how does that affect the economy? And that you can, and then just put sign plus or minus beside it and see what, how does it affect, and what is it a good choice. So that's something, and we are working on getting it together more, but it's not that easy. We're working to get that go there.
And I think you're already doing a great job, and it's super nice to hear also from the hospital perspective what is being done and what are your intentions. Yeah. So thank you once again, all of you, for participating today and for coming to see this amazing speakers talk about their solutions and about their ways of working. If you have any questions, like I said, you're still welcome to write them in the chat, and you will receive a follow-up email from us at the Nordic Center, from Emma, with some more information about this event in specific and about the World's Greenest Hospital. So thank you, all of you. Do you have anything you'd like to add?
No, that's it from me too.
Okay, perfect. And you're also very welcome to contact us if you are interested in showcasing in the World's Greenest Hospital. So thank you all again, and I hope you have a wonderful rest of your week.
Thank you so much.